Ramesh, for having me over, and thank you, Dr. Ashish, and other panelists. And my topic for today is treatment of choice in bicuspid aortic valve. Before I go ahead, thanks, Srinivas, for an excellent meeting. So, my talk is treatment of choice in bicuspid aortic valve. I am not going to go into detail of each of these because already Sengutuvelu has told you what are the challenges in bicuspid valve. Mainly the paravalvular leak, the annular rupture, PPI need, risk of rupture or dissection with an aortopathy, and of course, long-term durability of the TAVI valve because of the oval size shapes. So this is what you see, and many a times in a bicuspid aortic valve, you can see that you leave spaces behind the valve frame which can leak, and that is one of the major problems that they found in these studies, and that's why they were excluding initially bicuspid aortic valves in the randomized trials. This is the CBUS classification. Again, I won't go into detail of this, but the commonest we really see is the type 1 with the left and right fusion, and then the type 2 and the type 0. And this is the classification in the TAVI era, where it's tricommissural, bicommissural raphe type, or bicommissural non-raphe type. And this is how the frame expansion at different levels look like. The supraannular, at the annular, it looks compressed many a times, and this is how it looks at the annular side. So annular sizing in bicuspid is really a headache. Nobody knows, and nobody still is still evolving whether we should measure annular or should we do supraannular or should we do a combination of both? Should we do intercommissural? So this is how the annular looks in a bicuspid valve compared to a tricuspid valve. Similarly, we also need to have the measurements based on the leaflet and the calcium and the size of the leaflets. That's very, very important. So we need to do all of this before we can decide which valve will be best for that patient. And this is the reason we do that, because if you undersize, there's going to be a chance of pop out or a PVL or a valve embolization. And if you oversize, then there's a risk of high risk of pacemakers, annular ruptures, valve dislodgement, and excessive leaflet strain. So this has been discussed. So if it's a tube, generally we size on the annulus. If it is flare, we size on the annulus. If it's taper, then we size on the intercommissural distance. Data is very clear evidence of TAVR and BAV. This was the uh, meta-analysis in 2018, which showed that TAVI can be done equally well compared to tricuspid valve, but there may be a higher rate of PVL or lower success rate and higher conversion to surgery in patients with bicuspid. So the initial data with the earlier devices. Then came the Evolute low risk bicuspid study, which was presented by Forrest et al. They found that they got a good orifice area with 2.3, 2.2, and that was associated with almost none to mild AR. No patient had moderate to severe AR. So that again told us that TAVR with the Evolute supraannular expanding valve, even in low risk patients, achieved excellent results, and annular sizing achieved about 95% device success, low mortality, low PVL. As I said, no moderate or severe PVL was noted, and consistent hemodynamics across all classifications. And these patients will going to be followed for 10 years. Then came the another paper on bicuspid aortic valve morphology and outcomes after transcatheter aortic valve replacement. Here also it showed similar mortality in both bicuspid or tricuspid valves. And the most recent is the Bivolute X registry. It's a prospective registry at 14 centers. It's by Dr. Cheche et al. And it was going to assess the safety at 30 days, valve performance, ellipticity index, and follow-up examination at 30 days and 1 year. Is the first prospective registry that is in there for these evolute patients. And what they found in 30-day outcome, irrespective of annular or combined sizing, the all-cause death was reasonable, the cardiovascular death was reasonable, and there was not much difference between the two, with a pacemaker rate of almost 20%. And of course, the valve performance at 30 days was 98%, where the mean important thing is the mean aortic gradient was less than 20, and no or moderate or severe AR. And VARC to device success was 96%. Of course, there was no difference between sizing strategies of type 0 or type 1, and with a reasonable ellipticity index. So the Bivolute X showed us that an annular-based or combined strategy is efficient for TAVI in bicuspid aortic valves. Both the Pro and XL platforms, because the XL was used for 34, there's no Pro at that time for 34, gave us good EOAs, good gradients, and minimal AR in type 0 and type 1 BAV without an excess of ellipticity. That's very, very important. And the important thing, it showed us systematic pre-dilatation and tailored post-dilatation helps in preventing electricity, and repositioning capability of this valve is of particular utility in TIV for BAV. I'm going to show you just a couple of cases. This was a patient with a doctor actually with a fusion of the RCC and NCC, and there was a, as you see, I mentioned the perimeter derived and the LVOT. So we took a 34 valve in this, and you can see how we are positioning this valve. We start really in the middle of the tail, and then you realize this valve has slightly gone higher because it was 34. Then you quickly recapture the valve, and then you reposition it. And here it almost feels zero. And then you come back to LAO and you realize that you're well below the LCC. So you know very well that you're below the NCC, you're below the LCC. And this you can safely deploy it here. And then we check it in another view, and we also check in all the views before we deploy it so that we are not missing the any of the cusps. So this was almost a zero implant, and we almost had a single digit gradient with no EVL, as you can see. Similarly, another patient had an LCC and RCC fusion, same technique again. So you, once you decide that if your valve is moved up, as you can see in the second one, so we quickly reposition it, change your strategy. And this all can be done extremely quickly with the Evolute R. It's very, very tactile responsive. It 1:1 response, and you can easily reposition it. And with control pacing, you release the valve, and that helps in good position of the valve. This is again almost 0 to 1 implant with almost no PVL. So Evolute R in bicuspid valve anatomies, Evolute for TAVI requires valve frame implantation. You can depend on where you want to deploy it. You can ensure supraannular functioning almost always. You can always resheath, reposition, and supravalvular functioning, as I told you, is a relevant advantage. And this self-expanding nitinol valvular frame, it expands even in the post-implant period to conform to the anatomy. So if you have left a little mild PVL, which you have seen in many cases, and you do the echo after a day or two, you realize that the PVL has totally disappeared. And this in a BAV, you can often post-dilate. You can decide what you need to do, what valve size, what balloon size you are going to use. So identify a bicuspid valve morphology and criteria. Sizing concept in bicuspid still uncertain. We can use balloon sizing, we can use CT sizing, we can use the ICD or the Raphael length. It's not only about downsizing, but it's also best and correct sizing for the best EO is needed. Implant depth should be in relation to the anchoring zone. It's different from the annular plane to maintain supraannular functioning. So in a bicuspid, you can get slightly higher than a routine tricuspid. Of course, balloon sizing can be useful to identify the effective orifice area, so you know where the valve is going to seal. So yes, BAV is the same as TAV in terms of TAVR. An annular-based combined sizing strategy is efficient for TAVI in bicuspid valves. The Evolute Pro and Excel platforms demonstrate large EOAs, low gradients, and minimal AR on any type of bicuspid anatomy. You can have a systematic pre and tailored post dilatation, and the repositioning capability is of particular utility. So, according to me, Evolute is one of the valves to go for bicuspid anatomies, and it's a very forgiving valve. Thank you very much.